ฮัลโหลครับโอเคก็สวัสดีในช่วงบ่ายนะครับหลังพักเที่ยงนะครับก็ทางออนไซต์นะครับแล้วก็ทางออนไลน์เช่นเดียวกันนะครับก็เดี๋ยวขออนุญาตจะเริ่มเซสชันในช่วงบ่ายต่อเนื่องเลยนะครับน่าจะทานข้าวกันอีกเรียบร้อยแล้วช่วงบ่ายไม่แน่ใจว่าจะง่วงไหมแต่ว่าเนื้อหาน่าสนใจมากเพราะว่าจะเริ่มเข้ากับเกี่ยวกับเรื่องอุปกรณ์ครับจะมีทั้งอุปกรณ์ที่ใช้ตรวจแล้วก็ในการกระตุ้นครับในส่วนของปัญหาเรื่อง Pelvic floor ต่างๆนะครับโอเคพอดีเดี๋ยวจะต้องการในทางออนไซต์ครับพอดีต้องการ subject หนึ่งท่านครับที่จะเป็น volunteer ให้หน่อย Do you want to men or women? Female. ขอเป็นผู้หญิงนะครับได้ไหมหนึ่งท่านครับมีไหมไม่งั้น
No exposure, no privacy. It's really all covered. So,
โอเค
nothing is exposed.
ไม่มีปัญหาเรื่องจะ expose อะไรนะได้ไหมสะดวกไหมครับทางด้านหน้าสะดวกไหมท่านหนึ่งนะครับจะได้จอยกันโอเคไม่เป็นไรครับเดี๋ยวยังไงเดี๋ยวเอาทางสตาฟเราก็ได้ขอบคุณครับ
Okay. Good afternoon, everybody, and I hope you all had a good lunch. Those who are attending online, I'm sure they had a grand lunch than us, home-cooked food, and feeling fresh back to the session here. I'm going to This morning has been very engaging and a lot of new information I believe you were able to collect in terms of women's health issues, clearing about some anatomy, some physiology, and the pathological aspect of it, key aspect of assessment, evaluation. I'm going to shift the gear a little bit now and put the focus on a little bit on technologies that we can also utilize in order to enhance our treatment effectiveness. As clinicians, as physios, you are probably aware of many of these techniques and tools, and we will run through a quick refresher on these technologies and tools and see how they are going to be applied in context of women's health issues. So, looking at the electrophysical agents, we all use day and night in our physio practices for musculoskeletal conditions, right? You know, back pain, neck pain, knee pain, all kind of pains and aches. we are constantly using electrophysical agents. Now coming to this area of pelvic girdle, also we have to manage one major aspect, and that is the pain itself. So we are also dealing here with pain management. So this is this we created as a pathway to look at how we can, follow the treatment or modality approach for managing pain. So if you look at on a broader aspect, pain management, you have radicular pain symptoms or syndromes whereby you could use technologies like traction therapy. But in terms of non-radicular pain, either you could have acute or subacute or chronic, non-acute, acute or non-acute. So if you are in an acute stage, one thing is you try to avoid any kind of heat therapy. Okay, we don't want to have thermotherapy going when you are in acute stage. What you can work on is in ice. You can work on EPAs, which are going to resolve acute inflammation, such as pulsed ultrasound, laser, pulse shortwave. And if the client is non-acute, one of the key principles that we are working is also on a gate control model, okay? Gate control theories, and also endogenous opiate control. Okay? So in terms of gate control, we have heat, cold, E-stim, which is tense waveforms. We can use shock wave and intermittent traction. And also in endogenous opiate mode of pain modulation, we are focusing on electrical stimulation. Okay? So let's look at gate control first. If you're dealing with pain management, we actually use what we call gate control theory. Now, in non-acute cases especially, if it is superficial, we can use hot pack, cold pack. And these are actually doing sensory stimulations, right? In terms of deeper application, we can use continuous ultrasound, shock wave, short wave, laser. Again, subjected to which area you're treating, large or small, you can differentiate different technologies. Now, the gate control, as you probably know, and we'll just refresh, is basically we are trying to stimulate A beta fibers, right? We're trying to stimulate A beta fibers. So when these A beta fibers are stimulated, they get preferentially travel to the brain over A delta or C fiber, which are pain carrying fibers, right? So imagine if I hit my elbow here and hurt myself, what is my natural reaction? Is to rub. So why are we rubbing this? Why does our body tell us to rub? Is because our body is trying to do natural healing process and stimulating A beta fibers. So A beta fibers are fast traveling, fast conduction velocity fibers compared to A delta and C fibers. So when the signals are passing through the spine and there's a gateway there, so what happens, the more the fast coming impulses get preferably passed through the gate, and the slow moving impulses, which are A delta and C, they lose the running race. So they all are running. This is an Olympic going on between them to run and win the race, and the A beta wins the race. So this is where what happens is we get the sensory impulses going and less of the pain impulses goes to the brain. The whole objective of using electrical stimulation is to create neuromodulation. So we feel pain because our brain gets the signal of pain going from elbow to brain. If there is some way I can block these pain signals, my perception of pain will be diminished. Okay? So EPA, so anything that stimulates A beta fibers are able to create that gating effect. It can be done either by heat, such as a large superficial area, we can use hot pack, or you can use ultrasound, you can use cold, you can use mechanical stimulation like shock wave, or electrotherapy, such as TENS machines. Now, TENS is very common, easily available. And do you have an audio input? Do you have an audio input, speaker input? Sorry. I wanted to just share this little video here, and that gives you, okay, no problem. Okay, so let me just, I'll get back to that later. So one of the modality that we are commonly using in gating is the TENS, which is transcutaneous electrical nerve stimulator. So these are, I'm sure you are very familiar with TENS machines. Simple device, portable, home use, you can use for long term. Yeah. So these TENS machines are basically stimulating your A beta fibers, and that helps in moving signals over preferentially than the A delta and C fibers. Now, in terms of what we call high frequency or conventional TENS, is which works on gating mechanism, you can use waveform in terms of pulsed biphasic waveform. Also, interferential can also be used for interferential current can also be used for same mechanism, right? The frequency that commonly works is 50 to 120 hertz, duration of 40 to 100 microseconds, amplitude is on sensory level, and mode we set up on continuous. And you can use this modality whenever you feel necessity. It can be done, a number of times a day if needed. Yeah. So this is how a conventional TENS device would work. Okay, thank you. Let's try. Oh. No, sorry. Okay, that's fine. Oops. Sorry, we lost the signal. Just a moment, we'll be back. Okay, I think. No. Some entertainment.
มันไม่ใช่ duplicate การไม่แก้ duplicate กัน
Yep. So, who and when patients with pain, which is impairing their functions, that often happens, their quality of life is compromised, and or their participation in rehabilitation is affected due to pain. So EPA that gain pain transmission only have direct benefit for pain control while they are being used. That means there is a short-term effect of these TENS machines that you apply, and they are able to block the pain signal at that point, but the effect will not be lasting too long. After that, after a little while, the pain will come back. But what is very important to know how this modality works is because sometime when the pain signals are going from painful side to the brain, even though pathology may have resolved, but there is a constant transmission of signal that is happening, and these nervous system remember this path, and it keeps sending signals, and that is where a person transforms from acute pain stage to a chronic pain stage. So sometimes you come across patients who are always complaining about pain, and you assess, you don't find pathology, but they always complain about that kind of pain, and that's where the chronic stage happen. And to break that cycle of acute pain to get into chronic stage, TENS modality is very useful because it blocks these pain signals to go continuously, give a temporary break from this bombardment of signal that is happening. Okay. The other way of modulating the pain is through the opiate release, right? So just now we talk about gating mechanism. The other aspect of using the TENS machine is by opiate release, whereby we use lesser frequency of stimulation. Now, we have to use different parameters in order to facilitate opiates release into the body. Opiates is our body's natural pain relieving substance that is produced, right? In order to release that, we need to use low level of frequency. So classical settings you use is 1 to 10 hertz, duration of about 150 microseconds or more, amplitude as muscle contraction. Now that's the difference between when you're looking at gating mechanism and opiate release, is the intensity level here has to be at muscle contraction level. Okay. Many times people ask the question, oh, how much milliampere intensity should we be giving? There's no hard and fast rule about milliampere, because milliampere is just an output. There's a lot of factors that will affect the transmission of milliampere that you see on the machine to get into the body. And these variables can be your skin impedance, your location of electrode closer to the motor point, right? the electrode impedance, very important as well. So what is important parameter to look at response is the response of the tissue. So if you're working on a gating mechanism, your intensity has to be at a sensory level. If you're looking at working, if you are thinking, I'm going to go through the opiate release mode of pain modulation, your intensity has to be at a motor level of contraction. You should get a twitch of muscle, right? So we know opiates are produced when you work strongly and hard. Yeah. For example, now you see Olympics going on. You see all the athletes, soccer players. They're running, they're falling off, and they don't feel. They spring back and they run and they start running. They don't feel the pain because when you're exercising at that high level intensity, our body is producing a lot of opiates. So we don't feel pain that time. But after the game is over, then the guy realizes what he has gone through. So similar mechanism of opiate we can induce into the body by the technology, by using tense parameter simulation like this. One of the classical approach also has been is to use the tibial nerve stimulation. It's a very simple setup, as you can see in this picture. Stimulating tibial nerve has been found in a few clinical publications as an effective way to manage pain symptoms with pelvic girdles. And this, as you can see, is a very simple setup that can be applied to stimulate tibial nerve. You can also use such an electrode placement, anterior and posteriorly to stimulate large number of nerve fibers supplying to the pelvic girdle. And this is again very simple external application techniques. So these are surface electrode application technique that you can use. Apart from that, we can also use intravaginal probes, which can be like this here, and I'll show you here. So these intravaginal probes can be connected to the stimulators. So this kind of intravaginal probe. So typically, like you have two. So you connect the pin of the TENS machine in here, and this electrode can go inside the vagina, and it can produce better contact and better stimulation to the muscles. So, we have been, I was looking for some of the available literature in terms of TENS, and I could find this a nice reference. And this paper is published and says, does TENS reduce the intensity of acute chronic pain? It's a comprehensive appraisal of characteristic and outcome of 169 reviews and 49 meta-analysis. So it's a very nice compilation. Now you can see so much of work has been done and published in this aspect, in this area. And what you see in blue, of course, most of the studies have been concluded as inconclusive compared to benefit and no benefit, as you can see on three bars here. Most studies for chronic are inconclusive, but think positive. There are 33 studies which are showing positive outcome compared to 5 which said negative, or no benefit, not negative, but no benefit. In acute stage, certainly we found there are more studies which are positive. Now 24 are positive compared to 18 which were inconclusive. And you can see like this. So this data is quite promising that electrical stimulation or TENS, simple device like TENS could help in alleviating these pain. So one another aspect that we come across in managing women's health is the strength component. We know that muscle undergoes weakening and we need to strengthen these muscles. Okay. So using electrical stimulation in terms of neuromuscular electrical stimulation, we are able to enable or facilitate strengthening process. So just to summarize, what is NMES? NMES is muscular electrical stimulation. So we can do contraction by two ways, right? One is voluntary contraction. One is induced contraction. Now, voluntary contraction is when I think about a movement. I want to flex my elbow like this. The signal goes and I perform the movement, right? Okay. The other way of stimulating any muscle will be I put two electrodes on my bicep muscle, connect to an electrical stimulation, set the right parameters, turn the intensity on, and my elbow goes this way. That's induced contraction. Okay. So what happens when you apply the electrode to the muscle? The currents will, so when you apply the electrode here, so the current will pass through subcutaneous tissue and it will hit the motor nerve. So when the motor nerve are approached by the incoming current, these motor nerve will get depolarized and they will start inducing the contraction into the muscle. Okay. Now when we talked about normal contraction versus evoked contraction, which is through the electrical stimulation, one key principle we have to understand: when we do normal contraction, classically our type 1 fibers come into action first and some of the type 2 muscle fibers come into contraction. Our muscle are made up of type 1, type 2 fibers. Okay? But generally, type 1 are postural and static, type 2 are dynamic and explosive. So, but when you increase the demand on the muscle, suppose I take a 10 kilogram dumbbell and I lift it up. Now what's going to happen? I'm going to engage type 1 fiber and more of the type 2 fiber, so I am able to produce that amount of strength into the muscle required for the function. So that's a very basic fundamental. Why I'm saying is, this is important because when we electrically stimulate the muscles, it has reverse recruitment principle. When you electrically stimulate the muscle, it's the type 2 fiber that gets stimulated first, preferentially over type 1 fibers. So in order to stimulate a muscle, what is very important, when you apply electrode across the muscle belly, we try to target the motor point. If you are able to stimulate the motor point, you will be able to create a good muscle contraction at a very low level of output current. So the current is comfortable and you create good contraction. So this is a classic slide showing you neuromuscular junction. This is your nerve and ending into motor end plate. And this is where the nerve sends signals and communicate to the muscle to be able to generate contraction. So classically what happens when you apply electrical current, very first feeling somebody or patients was going to tell you is they feel some kind of tingling. So this tingling sensation is by superficial sensory nerve activation. Okay. When you increase the intensity, the current penetrates deeper, more deep sensory nerves are being stimulated. So you start getting more stronger sensation and vibration. When you increase the current further down, you will be able to reach the motor nerves. The moment motor nerves get stimulated, you start getting a bit of muscle twitching action. And when you increase the current intensity higher, you are able to get smooth, sustained contraction. And that is the level of contraction we need to accomplish. And that's the level of intensity we need to deliver in order to stimulate the muscle. So what happened in terms of physiologically changes, when the nerve is not conducting, it's at a resting stage, it has a polarity. And this is the difference in electrical charge between the membrane. So in a resting stage, the nerve is positively charged outside and negatively charged inside. So when you stimulate or stimulus is given, on the membrane we have the channels here. We have sodium channel and potassium channel. So green is sodium channel, blue is potassium channel. So at a certain threshold, the sodium channels will open up, making the positively charged sodium ion to rush in, and that create reversal of polarity. And this travels very fast into the nerve. And it's a rapid speed, very difficult to calculate this kind of speed. And this depolarized state of the nerve transmits signals across the nerve to the muscle. Okay? So this is called depolarization. And at a certain threshold, as you see here, when the depolarization sets in, the inside becomes positive and positive. So until it reaches positive 30, from the initial state of minus 60, the sodium ions will open, sodium channels will open up, allowing some the potassium channel will open up, allowing potassium to go out and then maintain the equilibrium. Now this sequence of depolarization and repolarization is called action potential. Now we generate action potential when we are actually sending these signals or the muscle is being contracted, right? Okay. So in terms of current and resistance also, it is important that we understand the relationship between current and resistance. So when you look at, if you remember school time, we learned about the Ohm's law, right? Ohm's law. Ohm's law state I equal to V upon R. All right? So I is your current. V is potential difference. R is resistance, right? So I is something, what you see on the machine, you set up 30 milliampere I want to give. Now what happens if suppose your resistance increases, right? If you suppose your electrode is loosened up or there's some break that's happening, then in order to deliver required potential difference, machines will ramp up potential difference, increase, so that your output remains same, right? So that's the relation between these two. So it is very critical that your electrode and your setup create least amount of resistance in that. Now in our own body, different tissue offers different level of resistance to the applied current. Remember, the more the water content we have in the tissue, there is a low resistance to it. So the high resistance surface such as bone. So if you apply electrode to the bone, you may feel hurting sensation. You may not feel so comfortable. Why? Because the current gets concentrated on the bony surface. It's not able to conduct through the bone. So bone, cartilage, fat and skin, they all create some amount of resistance. That's why when you put the electrode to the skin, on the very first milliampere, you don't feel anything. You need to increase because our skin is creating a resistance for incoming current. It does not quickly let it go. So in terms of frequency and intensity, frequency is number of pulses that we deliver per second. Most NMES protocols have used a frequency of 30 to 80 hertz. This is a common level of frequency depending on where are you strengthening. Okay. Now, remember, increasing the amplitude will increase strength of contraction. Higher the current goes, the deeper it tends to go in. And the deeper it goes in, it will recruit more motor units and strong contractions. Now, electrodes, they lose their ability to conduct over a period of time. A classical gel, electrode gel like one kept here, you can use 10 to 20 times, 15 to 20 applications. But every time you're using, their impedance, their resistance will go up. The resistance will go up because it is made of carbon material that get a bit burnt out, and you have your oil and sweat that will also create resistance on the skin surface. We have done measurement of these electrode impedance, and I can tell you fresh electrode and electrode that's been used 10 times, the impedance goes double or triple when you check on the meters. In order to decrease the resistance, it is good to clean the skin, shave the area if it is hairy area, use a wrap to improve contact. Contact should be good. If the electrode become loose, then the current will not be consistently, and it can create hot spots. You can add a drop of water always onto the electrode. Whenever you apply electrode, add a bit of water to reactivate the gel and conductivity. In general, hydration is good. If the person is too hydrated, the skin gets dry. If skin is dry, it will increase the resistance. Okay. Sometimes people use a little bit of hot pack to increase circulation so that the conductivity is better. And don't use moisturizing creams because that will have more resistance created. Okay. So these are the, some of the parameters that have been set up commonly for the overactive bladder. We are using intensity to maximum tolerable, low frequency, biphasic current, and so on. Okay. And this is, these parameters have been used in studies with stress urinary incontinence, and references given, Bergman's, this is from your resources, recommended by Margaret as well. And you can take these for your records, the slides. And for pain relief, I already covered quite a bit, and this is what parameters have been recommended as well. Okay. Now, another interesting aspect of technology that we are actually incorporating is to use the surface EMG biofeedback. Now, EMG is very valuable tool because when you're working with pelvic floor, it is very difficult to see how the muscles are being contracted, because it's not like bicep I can put, or quadricep I can put my hands on here and feel how the muscle is being contracted. Although, and what is the level of contraction? This is not visibly possible. And surface EMG biofeedback becomes a good tool in order to actually assess, evaluate the activity of these muscles. So it basically gives us ability to see through the aid of instrument, and it's an electronic way of feeling. It's like stethoscope for the muscle. Like you're using stethoscope to listen to the heart and lung sound. What EMG, surface EMG is doing, remember whenever there is a muscle contraction, there is change in the action potential of the muscle. Now what EMG is doing is it is actually recording the change in the action potential of the muscle and displaying on the unit in a numeric value. Okay? So it is opposite of what doing for stim. In the stim, we have a device connect to electrode. Electrode passes the current and make the muscle into contraction. In a EMG, we are doing other way around. We are actually making our own contraction, and the device is reading how much action potential is being generated. Typically we know that action potential travel through the motor neuron, as we see here, motor neuron, and then through these branches it will communicate into the muscle, and muscle will undergo contractions. Now, what we have to realize it in terms of EMG signals, it cannot capture all the deep located muscles. EMG signal will only be captured by superficial muscle fibers which are coming in contact with the electrode. So if these are the electrode, okay, you have skin, you have fat, and the superficial fibers like shown in the blue here are the one which will most contribute to the EMG signals. Okay. And this is how we actually show the whole signal processing. You have muscle and this AA. So AA and R is basically you have 3 electrode placement for EMG signal capturing. You have 2 active electrode and 1 reference electrode. So what reference electrode does is there is always a constant amount of signals because of electronics built in. So all these three will have common signals, including the electrical activity of circuit and the cables and all, or even the movement of the cable. The reference will filter out what is common between 3. So what remains is action potential generation. So it goes through a differential analysis, band pass filter, then you get raw EMG signals and reversal, tone degradation, and then you have signal representation. Okay? Because the raw EMG signals are very, they don't really make too much sense to us because they're like haphazard, movements of, and so as I said, we need to have, as I said, this will show you clearly. Now, these are 2 active electrode, and this is your reference electrode. So if the contraction of muscle is shown as the red, and yellow is the electrical signals, so the yellow is all filtered out. So what remains is the red part of it, which is your action potential. And that's how we do the filtering. So as you see, this is the raw signals. Right? And it won't make too much of clinical sense for us to interpret these signals. And after rectification, these signals are created in this way. Now, in this representation, we can see how strong you are holding muscle contraction, say, for 10 seconds. Is it smooth? Is it fluctuating? Is it not able to complete 10 seconds? That's very useful. So, advantage of surface EMG is it allows for functional movements, sensitive to low level of activity. Even small amount of activity change can be captured by surface EMG. Okay, it is responsible to small change and distinguish activity of particular muscle or group. So you can even differentiate with 2 group of muscle, especially in quadriceps when we work medius and lateralis. You can actually put 2, and then you can see the activation of 1 group, or emphasize the activation of medialis, for example. Okay. So this is how you actually apply the EMG signals. Right. Put the electrode and the reference electrode. These are 2 active electrode. These are reference electrode. So in terms of EMG is primarily used in traditional sense of aiding to strengthen pelvic floor muscle. So when you're doing pelvic floor contraction, the EMG is able to pick up the signals and show you on the screen how strong you are able to contract, how well you are able to sustain the contraction over the period of time. Okay. You can even work in terms of timing of contraction, protocols such as rapid contractions with this Okay. So treatment is, we always prepare the skin well, attach electrode. You have to tell the patient how or what they're supposed to be doing and perform the sessions. Okay, so this is exercise with EMG. This is a representation of how the weak muscles will be displayed on our EMG signals. It is not very clean and smooth. There are a lot of peak and valleys in these contraction, which is not a nice representation. Compared to, look at this as much better contraction, lesser peak and valley, and a defined rest period. So you can define work phase and the rest phase of the device. You can use surface electrodes, or you can use the intravaginal in case of pelvic floor. One another advanced feature that now we are using in technology is to actually combine EMG with stimulation together, which is called EMG trigger stimulation. Now EMG trigger stimulation works in a way, suppose if I put it on my extensor here, and I know my action potential generated here is, say, 100 microvolts, right? So I'll put on the machine threshold of 100 microvolt before current comes in. So I have to do an active effort, contract my muscle up to 100 microvolt. Once the contraction level reaches 100 microvolt, the current will automatically jump in and make the contraction go further. Now, the whole idea here is when you make your active effort, you are engaging most muscle fiber, your type 1 and type 2. But when you are stimulating by electrical stimulation, you are targeting different set of fibers, because electrical stimulation will target more of type 2 fibers, because these are supplied by more superficial nerve fibers, and you are able to get more muscle fiber contracted at the same time. And that's something we want to do. We want to engage more muscle fibers, get into contraction at the same time when we want to strengthen the muscle. So stim is a very passive phenomena. You're not doing stim. Electrical stimulation is making you contract. In a voluntary active effort, we do voluntary contraction, maximum of our ability. In EMG trigger stimulation option, we are combining both. We are using we are using maximum possible active contraction that you can reach. Only then the stim will come and complement you. Okay? So, some practical tips. Lead wire should always be looked up for these kind of electrodes. There should not be any having breaking in this or that. Avoid any stretching, twisting. Store them carefully. Okay. For the self-adhesive electrode also, check for short connectors. Everything is connected okay. Replace when you're not using, put them back onto the plastic that's provided with that. As I said, always try to use a drop of water before you apply to the skin surface. And because electrode life can be reduced by type and condition of your skin. If you're oily skin, then it will reduce the life of electrode. Deep-seated moisturizers, makeups somebody is having. So these are some common tips for vaginal electrode also. Connectors, look for it, and cleaning is very important. Remember, this is a single patient use device. We should not be sharing it. One other technique also we use is pressure measurement, home-based pressure devices, which can also be used to facilitate strengthening. And these personal use electrode or pressure probes are available, which is connected to the simple device like this. You can see here, And you can see how well you are contracting the muscles as a group of muscle to gauge the contraction. So these are some of the tools that we can actually use in terms of enhancing our treatment techniques that we are using. Okay. Right. So, okay. So I think what we're going to do now is do some practical and show you some of this stuff.
We swap computers again?
Okay.
Or do you want to do yours first?
Okay, I can
you
just
go
show
first.
quickly the.
Oh, yeah, just no hurry.
Okay. I can show you this EMG, how does it work in terms of, I can put it on myself just to show you the functioning of this. A quick one. So as I said, the EMG, we connect with 3 cables, 2 active and 1 reference electrode, right? Okay. So the white cable is your reference electrode and the red one running is your active electrodes. Okay, so I'll show you here. So the reference electrode, we prefer to put it on a non-muscular area because that's only to capture the signals and filter it, the common. Okay. Are you, it's okay? It's okay? Or you, I can come in front? So, here we go. So if you see here, yeah, thank you. Now I'll go here, setting, and I'm going to increase the EMG activity, work time, rest time. I can do the setting here. Work time, rest time, 6 second contraction, 6 relaxation. Number of trials is 10 times we can do. Okay. So now let's just make the target up. So if I contract like this, okay. So you see the system is prompting work. When I say work, I can start contraction. Work. Rest. So you get the audio feedback when I'm above the target. So if my target drops, there's no audio feedback. Work. So you see I'm getting fatigued. That's why there's more dips happening. Right? So you can imagine it can be a nice, powerful tool. And if the target is too high, I can simply lower the target just by pushing this down. Now, in order to do, I'll quickly show you the EMG trigger option. Okay, go home. We go into ETS, EMG trigger stimulation. I'll go and increase the current. You can see that 789 milliampere now is the current, and you can see my muscles have gone into contraction. It's stimulation. So this is stimulation. Rest. Okay, now what's going to happen? Work. But I'm not working. So there's no stimulation happening. Now I try to move. Oops. You observe what happened. When my red light reaches this target line, only the blue come in. The blue means current is on. Right? So now no. Okay. Now I do again. Okay. You see, the moment my EMG action potential reached the set threshold, this line here is the threshold line. This line is threshold line, target line, which is 145 microvolts right now. Here, 145 micro. Rest. Now I try again. Watch carefully. Work. I'm trying. Okay. Now the current goes on. The idea is when the current goes on, we should try to keep contracting. You are using electrical stimulation together with that. Now, work. I'm trying. Didn't. Air hit. It hits. The moment my red hits the target line, current comes in. So it's a combined technique of using EMG as well as, okay, I think should be fine. Yeah? And the, okay? Thank you.
We'll change computers as you change the voice and the Australian accent again. Get your brains in order. The next part of this session is going to be a demonstration. Excuse me. Dinesh, could we swap computers? Tech team. I've got enough battery. Link it in. Yeah, plenty. Yeah, completely. It's charged fully. I'm going to spend a few minutes describing how you could use ultrasound imaging. We might turn it down to see the ultrasound, if that's okay. Thank you. For pelvic floor understanding. As Dinesh said, it's really hard with the pelvic floor. You can't see a contraction. This is inside the body. Now, using ultrasound, it does give you an image of what's happening. So, unfortunately, I talked to one of you at lunchtime, but unfortunately I've just found out that in Thailand, physiotherapists don't use ultrasound. Well, today might be an introduction to tell people in your clinic, your hospital, how wonderful it is to be able for patients to see their pelvic floor work, and what a good biofeedback tool it is. In Australia, before we started using ultrasound for pelvic floor work, for any work, for musculoskeletal as well, the doctors were really against it. No, you can't use that, you're physiotherapists. The way we got around it was saying we are not using ultrasound for diagnosis. That's your field. We, as therapists, are using it for biofeedback and for rehabilitation. And if we know our scope of practice, if we know that that's what we're using it for, then we should have a clear definition, a clear delineation. Doctors and sonographers use ultrasound for diagnosis. We use it for rehab. So with that in mind, let me excite you about what you can do with ultrasound. Then you can go back to your clinics and excite them. So, what do we see here? In the top left corner, I have a picture of the setup. So the good thing about it is patients don't have to undress. All they do is undo the button at the top of their jeans or whatever. You drape that with a towel. Just lift up the top only to be able to see that they're not tricking with their abdominal muscles, and place the transducer on the abdomen. In the first slide, it's going to be what you'll see in the sagittal view, and the second slide is the transverse view. So let me trick your brains into looking at an anatomy diagram lying down. So here's the patient lying down. So you've got to have your anatomy lying down. Here is the pubic bone. Here is the abdominal wall. Bladder, uterus, vagina, at the bottom here, rectum, and anus. Now, if we use a curved transducer like the one we're going to use today, the beam that comes out of the transducer comes out in a fan shape, because every single beam of the ultrasound comes out at right angles, 90 degrees to that part of the sound head or the transducer. So here is the shape of the beam. Here's the transducer sitting on the abdominal muscles, and the beam comes out in this fan shape. So what you're going to be looking at is this anatomy, and then when they want the pelvic floor to contract, this black arrow tells you it's going to be up and towards the top left corner of the screen. So what does this all look like in ultrasound? Here's the transducer sitting on the abdominal muscles. Here is a big full bladder. And you can see that although our anatomy diagram tells you that it's like a round ball, in reality it's not. It's a very funny shape. See the uterus here? This is the round pear shape or the distinct shape of the uterus there. The vaginal walls are just a bit of a tube coming down that way, and you can hardly see the rectum. Here is the same anatomy, but with the pelvic floor contracted. So we put a marker on the muscle at rest, where it was at rest, and then we ask the patient to contract, and the patient lifted up that far, and it's towards the top left corner of the screen. So I know that was a good pelvic floor muscle contraction, and the patient can learn that too. Oh, that's my muscle working. It's not the muscle that you're looking at, it's the effect of the muscle as it pushes the bladder out of the way. So that's the first thing we'll do. I might as well show you the second one now, then we won't come back to the desk. So now if we do the transverse view, we turn the sound head or the transducer into a transverse or frontal plane, and now our anatomy is this. So we've got the transducer sitting on the abdominal wall. Here's our fan-shaped anatomy. And we're going to get the bladder. Unfortunately, I couldn't get an exact anatomy. So imagine that the bladder is sitting there. Here is the vagina. And what we have here is the abdominal wall, the round shape of the transducer, a very full bladder. That is an enormous bladder, I might say. Here is the uterus. And when we ask the patient to contract, the middle lifts up. And again, I put a marker on the patient when she's relaxed, and then another marker when she's lifted. And I can actually measure what the lift is. So it's all very simple, isn't it? We are measuring the lift component of the pelvic floor contraction. The anatomy is simple, and it's very, very effective for the patient to know what they're doing. So I think we have a volunteer from the audience, was that correct? Come forward and we'll get the tech guys to turn the camera away from the screen and onto the bed that we have in the front here, and we'll do a pelvic floor examination through ultrasound. Thank you so much for volunteering. In this position in the sagittal plane. Could you hold it for me? Thank you. And then we'll watch the beam down into the pelvis. But those of you who can see the screen can see that nothing's happening on the screen because we need transmission gel, don't we? We need it for our other... Now, when we use ultrasound for any sort of therapeutic reason, we need gel, and that's a perfect example of what we need now. Thanks for the moment. I probably need to see it a bit. Could the camera come round? Sorry. Sing a song. Get up and dance. So this is the transducer. Unlike our simple therapeutic ultrasound, which has one piezo crystal in their head, these machines have about over 100 crystals. Each crystal sends out its own single beam of ultrasound perpendicular to that crystal. That's why we get an image. So when we are doing ultrasound on a torn tendon or muscle, we're using a very primitive ultrasound machine. This is like a Ferrari compared to a Mazda. It's a much, much more exciting machine. Okay, I'm going to put some gel on the sound head now. Thank you. Have we got tissues to wipe later? Okay, here we go. This will be cold gel. Cold. Oh, no. Dinesh, we might need you just to get this working on here. It's not connected at this stage. For those who are online, unfortunately the ultrasound machine is not showing an image yet, so we're getting tech team to work it out. But you can see the position I'm in. I'm in a position where I can look at my patient. So we're a team. I'm going to be getting... normally I would have the machine by my side in the room and have the screen facing the patient. So the patient can see her pelvic floor lifting. And I'm facing the patient. So I've got a therapeutic situation. I'm not turning away. I'm actually talking to the patient because I want her to be able to tell me, to look at the screen and say, oh, wow, or that was a little lift, is that all I can do? Etc. we've had so many cables in and out of this poor old ultrasound machine, it's not in its normal functioning mode. I think that's our problem. Your shoulder will hurt soon. When all else fails, turn it off and get to default. Yeah, restart might be the easiest thing. Further. Yay, look at this. Woohoo, we have a fabulous image. You are going to be an excellent patient, my goodness. Look at that, isn't it perfect? Yes. So this is a full bladder. Thank you for being patient with us. Now, the top of the screen is the transducer. I'm in the sagittal plane, so I'm doing a slice through the centre of her pelvis. Now, on the left of the screen, there will be a uterus. I'm just getting in the middle line. So it doesn't really matter. We don't need to see the uterus, but that's just interesting if there was. That at the front, in the greyness on the right-hand side of that image, is the shadow that's cast by the pubic symphysis bone. Remembering, we all know that ultrasound does not go through bone, so we get that shadow on the right-hand side of the screen. Now, do you know how to do a pelvic floor exercise? Could you squeeze and lift your pelvic floor? And relax. And what did you see on the screen? Did the pelvic floor lift? Did that black hole in the middle, which is the full bladder, because we know that ultrasound just passes through liquid, doesn't it? Passes through fluid. So the bladder, did the bladder go up or did the bladder go down? Okay, let's just do it again. Can you do that again, please, Nina? Squeeze your pelvic floor. Okay, relax. We'll do it in. Okay, now squeeze your pelvic floor. And relax. Okay, so two things happened then. We saw a lift, but then she tried harder and the whole bladder went down. So I'm now going to treat you as a patient, okay? I want you to try less hard, be very gentle. Let's think about tightening around your vagina and pulling up towards where the probe is on your tummy. So upwards and forwards, okay? So have a go, just gently now. Up you go and release. Did it go up? No, sadly it went down. So this is what we would experience with a real patient, that's not the correct action. It's a lift. And you were trying so hard with your abdominal muscles. Your abdominal muscles were overpowering your pelvic floor. So forget your abdominal muscles, relax your hips. And now, let's have another go. And release. That didn't go down nearly as far that time. Let's do it again. That was a lift, and relax down. Can you see that, everybody? She did a great job then. Let's do it again. Watch that white line. See how it's going up? And now relax down again. Okay. One more time. Do it now. You've got the idea. lift, and relax. Okay, so because I'm only getting a very small lift in that sagittal plane, I'm now going to turn to the frontal plane. Okay, so now we've got the bladder in the frontal plane. You recognise that image? Do the same thing, didn't you? Oh no, the bladder went down again, didn't it? And I felt way too much abdominal work. So relax your hips. It's hard when you're on display, isn't it? I understand. Okay, so pull up through your vagina, lift inside of your body, and release down. And again, up through your vagina. Don't try too hard. Let it go down again. Okay, we're off screen now. All right, so do you feel, this is the beginnings of what work we would do with a patient. I would probably take you away from the screen now and do a vaginal examination so that you could feel the area. Could I touch you? Okay, under the towel, I'm just going to place my hands there. Can you feel there? I want you to pull away from there. Imagine that you're pulling away from your clothes. Sucking up and release down. That's better. Do that again. Suck up, yes, and release down. Can you see that, everyone? Suck up and release down. Now you've got it. Let's do 5 in a row. Let's do motor control training. Release. Gentle. You're doing it correctly. Do it again. Let it go. Now you've got it. Can you see the screen over there? Lift and release. Now as she's looking at the screen, lift and release. 2 more. Lift and release. Last one. Lift and release. Do you feel you understand that? Do you feel you've got it now? Yes. Oh, good. Thank you so much. That was excellent. So now we need the towel to wipe the gel off. Oh, actually, we'll use one of these towels that we're using already. Oh, thank you. Now you know how to do a pelvic floor exercise. There we go. I don't know whether I've got enough fluid in my bladder, but I'll do it on me. Do you want to do it on? Okay. I know I can do a pelvic floor contraction. Okay.
You demonstrate, I'll get it.
Okay, could you hold that for a moment? Excuse me while I just get ready. Okay, so there we have an image. Now, if I tighten, goes lift and release. Lift, release. Fast, go. Up, down, or hold it. Tighten, 2, 3, 4, 5, 6, 7, 8, 9, 10, release. So that's what you're looking for, okay? A responsive muscle that when you say tighten, it tightens. When you say relax, it relaxes. It's not sluggish, and it goes back to the original position at each time, okay? So that's what you're looking for. Do you want to see it again? Okay, get into the right position. Okay, lift, release. Lift, hold, lift a bit more, and a bit more, and a bit more. Now relax. So I hold for 3 and do...
Anyone volunteer want to try?
1, 2, 3, and lift, 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 and relax. Okay? So that's what you would want from a responsive pelvic floor.
Anybody want to try?
Anybody else?
Is there any different from the probe? I mean, when you like to see the movement of the report, you prefer transverse view, isn't it? I mean, the probe.
Yeah. Oh, do you want me to? Yes, I should show you the sagittal, shouldn't I? Oh, sorry, I'll put this back in again. Hang on.
Is there any more beneficial?
I like the sagittal for if I'm measuring, but I like the transverse if I'm not measuring. The transverse gives you often a better image, but the angle that you hold the probe varies so much that you can't get repeatability. From this week's appointment to next week's appointment, have you got the probe in the same position? Whereas the sagittal, it's much easier to do repeat measures. Which way? On each probe, there's always a little knob on one side, and it's a good idea for you always to put that marker either underneath or on the top each time, but it doesn't matter which one, as long as you always do the same one for repeat measurements, okay? Sorry, I'm trying to get the right. So the up and down, my uterus is very postmenopausal and little, and it's down the bottom there, it's in a different position. And I have a bit of a prolapse of my uterus too, being postmenopausal. So, but you can see the pelvic floor. Can you see that, where's it? No, I can't see the shape. Where's the marker? Pointer, there we go. There, oh, perfect, good, there we go. So, there's my uterus. Here's the wall of my bladder. That's my bladder. And my vagina would be along horizontal there. So I want this part where the pointer is to lift. Sorry. The whole pelvic floor is lifting. Not so much there actually, it's here there's more movement. Okay, so you can see that it's a good image either way. And it's quite a good lift. If you had a young girl who had not had children, the lift would not be as big because her fascia would be tighter. I've had children and I'm post-menopause, so I've got a nice lift of the pelvic floor. So, there we go, I'll just dry all the ultrasound gel off. Okay, thank you. All right, so do you like the use of ultrasound? Pretty good, isn't it? And we are not interfering with anything that a doctor would do or a sonographer would do. We are doing rehab. We are looking at muscle action. So if you can persuade your local doctors to let you do that, have a try. Show them what you can do. And then hopefully it will become a tool that is used everywhere in Thailand. It should be used. It is such a good musculoskeletal tool for us as physios.
I'll share with you because we had same situation in Singapore also, and I think about year ago we got complete clearance that physios can use it, because as we say, we are using for rehabilitation purpose, muscle training purpose. And not only this area, in our own practice we use quite a lot in core muscle training as well for back pain patient, to activation of transverse abdominis, multifidus, to segregate from internal and external oblique muscles activation, and it works fantastically. Patient really understand why they're supposed to be doing these basic exercises, and when they see themselves struggling to do isolated contraction with these muscles, they realize how important exercise is. And it's we had to put up a little argument and clarifications and make authorities realize that this is important, and we won the battle. Yeah.
Yeah, I think that it requires probably some leadership from somewhere in the professional organisation, the Thai Physiotherapy Association, or from leaders within the clinical world and the universities. If there is anybody here who is a teacher at a university, start teaching it in your electrophysical agents subjects so that the students come out knowing more than just the primitive therapeutic ultrasound. It's the same technology, it's the same energy source, just a much more updated technology. Question?
In your experience, because now we have electrical stimulation, like a biofeedback that we can measure about amplitude when we teach the patient to learn about how to perform exercise. In your opinion, which one is better in terms of if we would like to measure the progression of the exercise layer? Because we can use the ultrasound to see, can measure about the pelvic floor translation in like maybe in millimeter or something like that. Which one that you think is better to follow up? That is better.
For those online, the question is basically which is better to use to measure the pelvic floor progress, the baseline strength and then ongoing. I'm going to mention this in my next lecture, actually, after afternoon tea. There is no one measurement tool that measures everything that we want with the pelvic floor. It's a diaphragmatic muscle, like the diaphragm, and so it acts differently to biceps or hamstrings. It's not a linear muscle. So we need to measure an occlusion, a squeeze, as well as a movement, a lift. Sure, the TENS will measure the, it's more a treatment. The EMG will measure the lift, and that's probably a really good one if you're using a vaginal electrode. The advantage of the ultrasound is you don't need the vaginal electrode. So, but both of them work. Remember, one measures the electrical activity in the muscle and one measures the output of the muscle in terms of movement. And the other is your digital examination, measures more of the squeeze than anything. So there is no one tool that measures every aspect of the pelvic floor.
And the second one is, have the experience to do the pelvic floor muscle exercise in men. And if we would like to teach in men, how do we layer? Because in women we can.
Ultrasound only. Well, not exactly. That was a rash statement. The only entrance to the male body where there is a pelvic floor is the anus. But mostly you'll get the external anal sphincter muscle, not the pelvic floor. So you have to be skilled to go through the anus and up to the pelvic floor to get the pelvic floor activity. And many men don't like that. No. So if that's the case, then the ultrasound is the only tool that you have. Is there a male in the room that would be happy for me to check their pelvic floor through ultrasound? But there isn't, that's a question without notice, so that's hard. But for everybody, the image is pretty much the same. So you will see the bladder move, and that's what you're looking for, the lift. Yeah, so the men just don't have as many options. Okay, well, if that's all, we now have a quick break before we come back for the last session, and when we're going to get down to real physio practical business, how to teach pelvic floor muscle training and how to teach bladder training. What are you going to do with Kylie? Okay, have a quick stand up at home, off you go, have a cup of tea and come back.
We have one question from online.
So we have a question saying how to prevent interfere signals from nearby muscle in case a patient contract incorrectly. I guess it's important that we take right size electrode. That's important. Don't take too big electrode. The larger the electrodes you take, you'll get lot more muscles getting into contraction signals. So use small electrode. Generally, I'm taking, this was a big electrode, but normally we take much smaller electrode than this electrode. You want to add on?
Yeah, sure.
If it's a vaginal electrode, that you have no choice. You buy that electrode and it is that. But if the way to check whether you're using the right muscle with ultrasound is exactly as we found with our first volunteer. The bladder went down and I could feel abdominal muscle contraction really strong. So by touch and by vision, using ultrasound, you know when a patient is using the wrong muscles.
Okay.
Now you may go.
Okay. Okay, here. Thank you for answer. Okay, take a break. เดี๋ยวขออนุญาตเบรกนะครับเดี๋ยวเราอาจจะพักกันสั้นนิดนึงนะครับขอเบรกแค่ถึงบ่าย3:10 นาทีนะครับพอดีเดี๋ยวยังมีเนื้อหาที่น่าสนใจอยู่ช่วงต่อไปนะครับหลังจากเบรกจะเป็นเกี่ยวกับเรื่อง Pelvic Floor Training แล้วก็ส่วนของ Bladder Training ด้วยนะครับอย่าเพิ่งไปไหนนะเหลือช่วงสุดท้ายแล้วน่าสนใจมากนะครับหัวข้อนี้เดี๋ยวเบรกกัน10 นาทีครับขอบคุณครับ
ฉันจะไม่ไปไหนจะไม่ทำให้เธอ
ไม่ให้เสียเวลาอย่างนั้นเดี๋ยวขออนุญาตเริ่มต่อเลยนะครับเพราะว่าเป็นเซสชันสุดท้ายแล้วเป็นในส่วนของ pre-for training กับ bladder training right โอเคครับอย่างนั้นขออนุญาตเชิญดร. Margaret ครับ
Thank you very much. So that was a short break, and I hope that you all had a bit of a chance to stand up and get refreshed. To finish the day, we're going to be looking at physiotherapy for bladder dysfunction. Now, I have entitled this presentation as to be bladder dysfunction to go back to the case study of Kylie. So at the end of the day, we're going to have a discussion about Kylie, but in the meantime, we're looking at pelvic floor muscle training and bladder training as our two main treatments for management of bladder dysfunction. So, as physiotherapists, we work with muscle. And in Australia, at least, and I don't know what it's like here in Thailand, but patients usually do link pelvic floor muscle exercises with physiotherapy. They don't go to a chiropractor or a nurse or anybody else to have pelvic floor exercises. They come to a physiotherapist. So that's great. We've done a good job of selling this part of physiotherapy to the general public. Now, if women in Thailand don't automatically think of physiotherapists for the clinician that they should go to when they need to get some pelvic floor exercises, you have a job to do. So you can go out from here today and start selling physiotherapy to all the medical profession and all the women of Thailand to say, we are the professionals to come and see for your pelvic floor muscle training. But most people don't come to you. They might know that, but they don't come to you because they want to learn the exercises. They usually come because they have a clinical problem, like bladder leakage, or a weak bladder, like Kylie, or urgency, or getting up at night too many times, or pelvic pain, or pelvic prolapse. And what you do as a physiotherapist is use pelvic floor muscle training as part of your management. So, what if women in Thailand do not link pelvic floor muscles with those symptoms? Like Kylie didn't. She came to the physio and said, I've got a weak bladder. So, if you start giving pelvic floor exercises to someone who's come with a bladder problem, they might say, well, I think she doesn't understand what's wrong with me. And you're going to have a great big problem if the woman does not understand what's the linkage between pelvic floor exercises and bladder leakage. So let's look at the evidence again. So I'm showing you a couple of slides in this presentation that I've shown you before, but I want to link them to a clinical situation now. So you know this, I told you this earlier this morning, that pelvic floor muscle training, our evidence is grade A recommendation, level 1A evidence, that pelvic floor muscle training should be offered as first line therapy before they have surgery, before they take medicines, before they do anything, they should have pelvic floor muscle training. It is such strong evidence. But we've got to explain the link to our patients, that we can't expect them to just have understood that without any education. So I'm going to go through now how you might explain the anatomical linkage and then the neurological linkage. And in your program today, there were two sessions. One was pelvic floor muscle training and the next one was bladder training. But because they are so interlinked, I'm doing them all in the one presentation. So let's think about what we might be wanting to do with pelvic floor muscle training. Oh, by the way, may I interrupt myself? I have added some more slides in, so you will come across some slides in this presentation that you don't have on your printout. I can give you I can give the organisers an updated presentation, or otherwise you can just take more notes. So, when we are doing pelvic floor muscle training, we need correct contraction. No, we can't do anything if the patient is not doing it correctly. So we have to, first of all, teach correct motor skills. I've put this diagram or this lovely image of a drop of water dropping into a very still pond and the ripples coming out. Let's rewind that video, bring those ripples into the centre and the drop of water lifting up out of the picture. That's a nice gentle image for someone who is trying to work out where these pelvic floor muscles are. And you might do it now while you're sitting there. Imagine, the girls, that you're tightening around your vaginal entrance and then lifting up into your pelvis. That's the correct feeling for a pelvic floor exercise. Men, it's different. Usually we say, men, make your penis shorter and pull up towards your belly button. Whatever image, but think about bringing the ripples together and then lifting up through the pelvis. You don't go any further until the patient has the correct action. Otherwise, you're giving them the wrong information. They'll never get better. It may take a few sessions. And you know, all your motor skill training from your neurological physio work, just all the stuff you do with neuro patients, you bring into action with your pelvic floor patients. Once you have the correct action, then you can start strengthening. Then you need your neural adaptation and your muscle hypertrophy. And what does it take? High adherence. You'll give the patient lots of encouragement to work at it. You might spend some time with the patient saying, now, when could you do these exercises at home? You have 3 small children. Is there any time during the day that you could do a set of exercises? And Kylie might think about it and say, well, I could do it before I get out of bed in the morning. Excellent. So let's make a contract that you do them every morning before you get out of bed. Or in the peak hour traffic coming home, I'm sitting in the traffic for 20 minutes and I'm by myself. Okay, what about doing another set of exercises in the car? So you work out with the patient when she could do her exercises. Don't stop there, because that is isolated muscle re-education. It's not putting the pelvic floor muscle into the body. So next stage, and the final stage, would be to get her to do the pelvic floor exercises while she's doing something else. It might be while she's working, while she is walking. And one of the easiest exercises, I'll walk away from the microphone, is to tighten for 4 steps, relax for 4 steps. Tighten, relax, tighten, relax, tighten, relax. Now, I only did 2 steps, but it's a rhythmic tighten, relax. And she's doing it while she's doing walking. Or it might be when she's going upstairs, or standing at the kitchen bench chopping the vegetables. There could be any number of times. So you need the functional training as well. So you could ask yourself, is there a best retraining program? Well, if we follow normal strengthening protocols, it needs to be progressive, needs to be resistance, high volume, and if you don't do high volume, get no effect or just a small effect. For training any skeletal muscle, it needs to be for at least 15 weeks. So that's 3 months. So advise your patient that they will be doing this for 3 months. You might say, but what if I've got an older patient? So we went through the changes with older people. Yes, it might be in a healthy older patient that you could do a program like this. Of course, you'll do functional training as well. But remember that older adults, they might gain strength, but they won't hypertrophy like young ones. So factors to consider are the initial state of the muscle. How disused is this muscle? Has the patient never done exercise? Have they been sedentary? They haven't walked or done any exercise, so it might be a very under-exercised muscle. Then what are your goals with training? What does the patient want? So some patients, like Kylie, she wants to go to the gym and be able to do her exercises without leaking. So you've got to then think about, well, what gym exercises is she doing? Are they weightlifting, or is she doing running on the treadmill? Is she doing a rowing machine? So match your training program with her goals. They might not be your goals, but they are her goals. So do you want force? Do you want velocity? Do you want endurance? Or all three? Remember that with progressive training, you are damaging the muscle. Every time we strengthen muscle, we have to do some damage to the fibres and then they repair. So there might be a lot of delayed onset muscle soreness, DOMS, in the early phases. That's fine, no problems. We do it. Every athlete gets muscle soreness. The difficulty is in the pelvis. The patients get a pain just above their pubic bone. They think, oh, something's really wrong. Now I've got a real illness. Something's wrong with my uterus or my bladder or my bowel. And they become very fearful of exercising. So before you give them a really good strength program, please let them know about DOMS, about muscle soreness with exercise. I showed you this picture before in the other lecture. One's similar anyway. I'm not sure that I showed you this one exactly. I'll just get the laser pointer up. Hang on a moment. So here we have a cross-section of the pelvis with the abdominal muscles, pubic bone at the back, sacrum and coccyx. We have the rectum coming down to the anus, uterus and vagina, bladder and urethra. And underneath all of that is the pelvic floor. So if a patient comes with a bowel problem or a prolapse problem or a urinary problem, the unifying structure that underpins all of the function of those three systems is the pelvic floor muscle. So it seems like it's got a huge role, and yet it's not a big muscle. So yes, we do need to educate our patients, educate our referring doctors that this is a very important muscle, and the position and the function of the three different organs sitting on top is the unifying factor is the muscle. And remember me saying earlier that the sphincters of the urethra could also be tightened and firmed up by exercise. And remember that I said it was just the voluntary muscle in the mid-urethra that we can affect. And we can only affect it by actually doing a pelvic floor exercise to tighten at the front, around this urethra at the front of the muscle. So we are looking for urethral closure when we do the pelvic floor muscle contraction. It has to be strong enough to press the urethra to the back of the pubic bone. We're looking for a forward and upward movement of the pelvic floor muscle. And it's a good idea to test the strength of the muscle against a force and intra-abdominal pressure. Now, you're not going to get the patient to cough or sneeze and tighten the pelvic floor muscle against that at the first visit. One of the things that we do is to get a patient, and I'm going to get you to do this in a minute, to tighten the pelvic floor and then do a forced expiration, maybe like a s or a sh things like that. So could everybody sit up and do a tightening of their pelvic floor? Hold it tight while you go or shh, and then let it go. And you say, could you hold it? Maybe you couldn't hold for that long. Maybe it's a 3-second hold. So everybody now do it with me at home too. Tighten up your pelvic floor. For 3 seconds, do a shh, 1, 2 seconds, 3 seconds, relax. So that is as an exercise is getting the patient to tighten their muscle against that downward movement of the organs and the increased intra-abdominal pressure. And what I tend to do to progress that would be to do it harder. Shh, 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 or t, 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 pa, pa, pa. All those expulsive use of the lips and the tongue, and get the patient to hold their pelvic floor against those activities, so that they learn to add strength and function to their pelvic floor. Now, I was asked a question earlier about measuring the pelvic floor, muscle grading. Do you know what? We use exactly the same Oxford system as we do for skeletal muscles, except that we have to add squeeze and lift. So occlusion, in English, is to squeeze. So it's a modified Oxford scale. 0, nothing, 1, a flicker, 2, a weak pressure with probably little lift. Grade 3 is the most common, as it is for every muscle. 4 is strong, and 5 is normal. Now, it's really hard to make a decision about which grade the patient is at, because you've got to combine how much squeeze are they doing versus how much lift are they doing. It's hard, isn't it? But we do the best we can. We haven't got a better way. Now, these are the slides I put in extra, so if you want to take notes, take them, or I'll send this version to the organisers. The International Continence Society, the ICS, International Continence Society, which are a group of the most esteemed researchers in the world, looked at our modified Oxford scale and said, rubbish. You physios can't distinguish between 6 categories, 0 to 5, and they thought we should have just absent, weak, moderate, or strong, 4 categories. So if you just write that on your notes, absent, weak, moderate, or strong, that's fine too. It's also a good idea to record the relaxation. If patients have got an overactive pelvic floor, they find it hard to let go. So patients with pelvic pain are hanging on. They never let the pelvic floor muscle go. And so when you get them to tighten the muscle, they can't let it go. So you're teaching them to relax the muscle rather than tighten the muscle. And for some patients, they tighten and they let go a bit, and a bit more, and a bit more. It's like a cogwheel letting go. So it's a good idea to report the relaxation as well, absent, partial, or complete. So how are we going to evaluate our muscle and strength? We're going to do our manual muscle testing. This is our vaginal examination, and use the scales I've just talked about, even though they've got conflicting reliability. We can use one of the machines, the machine that Dinesh mentioned just at the end of his session, the pressure biofeedback, called a perionometer, perineum and a meter. But there are sources of error I'm going to talk about later. And there's been most development in manometry. That's where a lot of research is going on at the moment. Dynamometers are the same sort of thing, measuring the force of the muscle. I'll tell you a very sad story about this. This researcher, her surname is Dumoulin, she's a French-Canadian physiotherapist. She was doing her PhD And she and her engineer father had developed a dynamometer at home in their garage, and she used that to measure the force of the pelvic floor muscles. It went into the vagina, and it had 2 arms, and it measured the tension in the muscle, actually in newtons. It was a proper dynamometer, not just a pressure device. And she published her first papers, and to their absolute dismay, a business person in the United States took out a patent against it, and she was never able to develop it into a clinical tool because this man is asking for millions of dollars to get her dynamometer back to be developed. It's such a sad story, and for university researchers it's really important to know this because if you develop a new device or have something that's new, patenting it, although it's expensive, is what you have to do these days. So I've put dynamometers in there just to tell a very sad research story, but if someone could eventually develop a dynamometer, that would be fabulous. Now, we lift weights for biceps, everything else. Can you lift weights for the pelvic floor? Yes, you can. You can put an intravaginal device, a device in the vagina with different weights in it, and teach the woman to walk around or just immediately to stand and tighten the muscle to hold the weights in the vagina. And there are all sorts of ones. Many of them are available at sex shops, but there are some clinical ones available at pharmacists and maybe at Boots or somewhere like that. There are vaginal weights for adding weights to your pelvic floor exercises. Unfortunately, there's poor research in this area, but look, we use weights for every other muscle in the body. Why not the pelvic floor? Seems to me it's okay. So then we have to think about, what are we measuring? Squeeze or lift? So the lift measurements are ultrasound, as we saw today, and expensive, but MRIs as well. We can look at the location of the pelvic floor, how thick it is, its anatomy, using ultrasound and MRI again. But I want to say right here and now, no single method is able to measure elevation and the compression force. So to answer one of the questions that we had at the end of the last session, sorry, we have no real way to measure the pelvic floor muscle completely. We can measure the lift with ultrasound, we can measure the squeeze pressure with our devices, measure the EMG, but it's not the full picture. So it's a combination. Best current method is a combination of observation, correct action, vaginal examination, and the squeeze pressures. But no matter what way you use, make sure you standardise your palpation method and standardise your reporting. Make sure you always put the patient in the same position, use the same force, use the same tool and report so you get reliability. It's pretty bad, isn't it? Unfortunately, I haven't got any good news for you there. So no single measurement tool gives the full picture. And we haven't got any tools until just now. There's a new one coming on the market I'm going to talk about with Dinesh that has wireless, and it can measure the pelvic floor force in walking, running, squatting, leg lifts, etc. If it comes to Thailand one day, it's called the FemFit. Okay, so when we're doing our pelvic floor exercises, this is a homemade slide of mine. We just think about any sort of exercise that we do where we want the repetition maximum to match our aims. So if we do 2 reps up to 20 reps, our training goal, if we want strength, we do a lower reps. Power, lower reps. Hypertrophy, middle range, 8 to 12. Endurance, 15 to 20 reps. You all know that. I've just put it in there for a reminder. So if we ask, is there a best retraining method for the pelvic floor? Yes, same as anywhere else in the body. Progressive resistance training program, high volume program. Patients need to do their exercise every day with the understanding that if they don't get the gains. 3 months duration, And I've told you this before. I didn't realise I put this in twice. I got really keen on it, didn't I? So now, let's think about some tips and tricks. What cues might you give the patient? So, if you're talking to the patient, like we were before, what words could you use to get the patient to work better? Squeeze, lift, work harder, lift higher, use your voice a little bit more enthusiastically. So think about the words, think about the action of the muscle, and then add your words in your language, in your personality to match what you're asking. Because the pelvic floor is inside the body, you might need some anatomy charts. In fact, you will need some anatomy charts. Do not attempt to do this work without understanding the anatomy or giving the patient a chance to understand their anatomy. It might help the patient if they feel themselves. Now, I asked our patient before, could I please touch her? And what I did under the towel was I just did a little tap, you know, the neurological tapping the muscle, and that got the idea of where to work. It was a kinesthetic stimulation. What other ones? You could get the patient to give some pressure over their pelvic floor. Any sort of sensation that gives a kinesthetic input, gets their sensory nerves understanding where to work. And avoid the trick movements. Now, what trick movements? Today we had using the abdominal muscles too much. Another one is breath holding. So, and holding up like that. Lifting the shoulders, tightening around the mouth, squeezing the eyes, all these sort of tightening the adductors, you know, pressing the legs together, bending over. There's half a dozen more trick movements that patients do. Do not allow them to do that. It has to be maintaining normal posture, like we talked about with the capsule, the dual role of dynamic movement and postural control. So be aware of all those trick movements. I'm not going to spend more time on that. If we were doing an actual prac session, that's where we would spend a lot of time. I'm giving you just a few hints to start off and for you to think about the fact that if you are teaching a muscle to act, a muscle that is inside the body, you have to be very agile, quick with your language, and you are making a difference to the patient's understanding. But now, we're going on to think about physiotherapy management being more than pelvic floor muscle training. We have to get clinical. We have to think of the signs and symptoms and risk factors. How can we assist our patients to eliminate these? Well, we might use trainers, the ones that Dinesh talked about, but there are quite a lot on the market that patients can get hold of themselves, online, eBay, or whatever. You need to know about these and know whether they are good or not. So they all, here's 4 different brands. They usually have an app that you can look at on your phone. So if the patient comes to you talking about the Loop device or the Kegel, the Skier, the LV or the PeriFit, or there's, I reckon, 20 of them on the market, at least know about them and be able to say what you think about them in terms of are they useful or not useful. Now, the other thing is addressing risk factors. So let's talk about stress incontinence. This is Kylie. She gets leakage with increased physical stress. So if a patient is doing lots of activities that increase the downward forces on the pelvic floor, you need to do something to change that. And understand them about the non-modifiable ones, the ones you can't change. She's had 3 babies, she's 55, so she's going through menopause. Or She's a patient with really hypermobile joints that's got very loose fascia. Now, I've been through these slides before, so I'm not going to spend time on them because we now know about the pelvic model, and you can have a slide like this or an anatomy diagram like this that you can show your patients. Don't let too much pressure come down on the bladder or the bladder will just fall backwards. So what are these activities that might cause intra-abdominal pressure? And how might you change them? So let's look at the diagrams. Maybe talk to the person next to you at home. Think about it yourself. What would you do with the patient here, coughing patient, and this patient? I want 4. You could do 4 different things with these 4 different patients. I'll give you 1 minute. Go. Talk. By the way, this patient here is supposed to be constipated. So, a minute's up. What might you suggest to a patient who is constipated and who strains on the toilet all the time? Might be change your diet. It might be, or we don't know if it's the pushing or if it's the closure of the anus. Maybe she's got dysfunction. So that requires 2 possible ways. Diet change, so has soft stools to pass, or doing some anal investigation to see if she's got good control of her anal muscles and can relax them. This picture here, can you see this stream? So this is an Olympic athlete. So even the top level athletes still leak. What would you suggest to someone like that? This is really hard. Because if she is training to be an Olympic athlete, and this picture was taken at an Olympic Games, and she has given permission for this picture to be used for educational purposes. So it's absolutely fine. We're allowed to talk about her. You might say immediately, oh, don't lift such heavy weights. But I want to go to the Olympics. I'm really good. I need to train. So then you will have to think of other ways around this. There might be that you ease back on the training for a little while or change the style of training while you are doing a pelvic floor training program. It might be that you need a sports coach to look exactly at her posture, or her form doing that exercise. Could she change it slightly so that there's not so much strain on her pelvic floor muscles? But I'm sure she won't stop training. This lady here with the chronic cough, get your cardiothoracic doctors involved and make sure that she's on medication to stop the cough. And this lady here, reduce the abdominal girth, reduced waist circumference. It's all that weight that's just sitting on the bladder that is causing her to have leakage, just her body weight. Okay, so that's the mechanical stuff. That's the pelvic floor muscle training. Take a deep breath, because now we're going to change to the neurological training, the bladder training. Are you ready? Shake out a bit. Okay, so I'm going to consider this under overactive bladder, because if you remember that the overactive bladder was a complex of symptoms, and it's urgency, incontinence, it's that frequency, going to the toilet too many times, and it's also getting up at night. So let's assume that the doctors have cleared any other things like infection, cancer, metabolic syndrome, MS, Parkinson's, those other neurological conditions. This is just a bladder problem. But of course, if you are working in this space, you must work in a team with a neurologist so that you get these other, or an oncologist, anybody, a GP, to clear the nasties out of the way. So what are the risk factors? Oh, it's hard to define really, because it's just a symptom complex. I can't give you a real answer. It could be the nerves, the motor and sensory supply. It could be the muscle. It could be something within the detrusor muscle. Or it could be a cellular problem on that inside lining of the bladder. So it's really, really hard. I've put this here just to remind you. You can look at it again, of the neurology. Just remember you've got all those nerves going into the bladder, all those autonomic nerves, sympathetic and parasympathetic, and you've got the somatic nerves coming into the sphincter muscles and the pelvic floor. So they're your two major major nerves. And I've just put circles around both the parasympathetic and sympathetic supply. But now we're on to the most important slide of this lecture. How to manage overactive bladder. And I'm going to start at the top with education and go around the circle. And I'm going to leave that neurological diagram in the middle so that you're always thinking about nerves. So, education. I'm always going to the toilet. I'm getting up every night. It's ruining my life. I can't go out. I can't sit through a movie. It's just awful. How do you explain to a patient the nerves? You'll need to understand the neurology of the bladder in a simple way that you can explain it to the patient. It might be that you don't worry about all the autonomic nerves, although I often do. I would often say to a patient, we have two different systems of nerves in our body. We have nerves that supply our muscles. You can see I want to bend my elbow. I bend it and the nerves go to the muscle and it works. I can't do the same inside because that inside organs are supplied by automatic nerves. And in the official term is autonomic nerves, but they're actually automatic, aren't they? And so we are changing the automatic nerves through your brain and through exercise. So something like that. You'll have other words to use. How do you explain it to stroke patients or MS patients when they've got nerve damage and you are using exercise to get to their damaged nerves? It's the same. So you'll have words from your other parts of physio. Second one, calming strategies. If we think about the nerve supply up to the brain and that the pons is very close to our emotional system in the hypothalamus, then calming might be helpful. Take some deep breaths. When you get an urge to go to the toilet, don't rush. Sit down. Do something different. Take a deep breath. Breathe your way through the urge and use your voice in a calming way that makes them go to sleep. And at this time of the afternoon, you may all start closing your eyes, I understand, but use a gentle, calming voice. What about distraction? This is another way of getting the brain to work. Sit down, take some deep breaths. Now start counting backwards from 100 by threes. 100, 97, 94, 91, 88, etc. Something that distracts them. Or make a phone call to your mum. Or feed the cat. Or ring up about the gas bill. Whatever it is. Something that distracts you. And many patients will say, you know, I did something, I did an activity, the urge went away for hours. I didn't have to go to the toilet for ages. So it does work. But another thing to do is timed voiding. Say a patient has early stages of dementia or is unable to remember to go to the toilet or doesn't have the inhibition strategies to calm down. It may well be that you set them a timetable of going to the toilet every 2 hours, 3 hours, whatever it is. Put an alert on the phone, have the alarm go, and they go to the toilet regularly so they don't overfill their bladder. The next one is to change their toilet habits. What do I mean by that? I mean, you all have, I'll start again. Everybody has their own habits when they go to the toilet. You might not think you do it the same way every time, but you do. Next time you go to the toilet, when you take your pants down, if you find that you always face the toilet, go the other way, face away from the toilet. If you always look at a picture on the wall, don't look at it, go the other way. It doesn't matter how little the change is, it is a change, and it makes you do things slightly differently. So change your toilet habits. Maybe put some smelling oils or something in the bathroom that affects your other senses, like a smell or a picture, or take a book into the toilet. All those sorts of things that make you think about what you're doing. You don't, not just going habitually. We've talked about the pelvic floor muscle exercises, and of course that's what the pudendal nerve is going to do. And there is a reflex. The stronger your pelvic floor muscles are, the more relaxed your detrusor is, and vice versa. So pelvic floor muscle exercises work for an overactive bladder as well. Perineal pressure. If someone has really strong urgency, just putting some pressure up on the perineum, holding yourself is a good thing to do. But that's not a very adult thing. You can't go around the shopping centre holding yourself. So what can we do as adults? That's what little kids would do. But as adults, you can't do that. So maybe you could just cross your legs and talk to somebody with your legs crossed, or sit on the edge of something firm like the edge of the desk or the arm of the couch, or just lean forward a little bit. We can very subtly apply perineal pressure. If you're at home, do what the kids do. But if you're out, do something else. It might be as simple as you're all sitting on the chair in a certain way. Why don't you now just try this? Rock your pelvis forward, arch your lumbar spine, so you're sitting on the front of your pelvic floor. And you find, oh yes, that is pressure. So even altering your posture as you sit gives a different pressure on the pelvic floor. There are lots of good ways that you can teach people. Now, S2 myotome stimulation. So we said S234 is the pudendal nerve supply. What else does S2 supply? Ankle, calf, down in the foot. So it may well be that doing some ankle and foot activities stimulate the S2 nerve trunk enough to decrease the understanding of the brain, or the sensation that the brain receives from the bladder. So you might get patients to up and down on their toes, or to scratch their calf, or to do some heel-toe walking, or just jiggle on their feet, like a kid would do. Has anybody got little children at home? When they go to the toilet, they just jiggle all over the place. They don't know it, but they're stimulating their S2 myotome. Maybe you could teach adults to do this in a more adult way, but it helps decrease the brain's perception of urgency. Acupressure or acupuncture. There's a lot of research to say how good acupuncture is to reduce urgency. but we can't send everybody off to acupuncturists all the time, so could they just use pressure over some acupuncture points? One of the best ones and easiest to teach is the one just at the base of the nose here. And it's one that people can do in polite company. Just scratch the nose like this. Just jiggle here. You could still be at the dinner table or talking to friends. You might do it with a tissue in your hand, like you just got a bit of a sniffle. It's easy to do that. It's a pressure about 45 degrees up into the base of the nose. If you don't have any urgency, you won't feel anything, but those who have urgency go, oh, that's a bit tender. The other one is down above the medial malleolus. So 3 fingers up from the medial malleolus, just behind the tibia. So I don't know whether you can get that on the screen. Medial malleolus, 3 fingers up and just behind the tibia into the posterior tibial muscle. That's another good point. And people don't have to bend down and do that. They can use their heel of their shoe doing it, their toes. It's one that's easy, accessible for people to stimulate that acupressure point to assist with reducing the sense of urgency. We've heard a lot about TENS today, and Dinesh has given us lots of introduction to how to use it. Here we've got some places to put your electrodes if you're using it for neuromodulation of the nerves to the bladder. Over the sacrum, over S234, over the posterior tibial nerve, so just below the medial malleolus and into the posterior tibial muscle, or over the bladder dermatome, just above the pubic bone, either side of the midline, as I said, just above the pubic symphysis. So you've got 3 different places that will activate, or you can access, the nerves that supply the detrusor. Moving on. If you have bowel issues, bowel constipation or bowel urgency, remember that the bowel is supplied by the same nerves as the bladder. So a really good way to treat bladder urgency is to treat the storage part of the bowel and the rectum, where bowel motion, solid waste is stored in our body, like the bladder stores liquid waste, the rectum stores our solid waste. To treat that, to make sure that people are not constipated, the easiest way is by dietary change. More vegetables, less fat, etc. Do you know what I've noticed in Thailand? Donuts are so popular. I've never seen so many donuts in all my life at the stores and around. Stop eating food like that. That just clogs up the bowel. Way too refined, sugar, flour. So stop them eating donuts. And here are some other dietary changes. Reduce caffeine. That has an effect on the bladder lining, that urothelium. Reduce fizzy drinks, the lemonades, the really... Coca-Cola is one of the worst. Ban Coca-Cola. And acidic foods, like strawberries and mangoes and things. And make sure that the water intake is suitable for their body. For some women, that means increase the water intake. For others, it's decrease. So that's why I put just alter it. And here's a good chart for you. It's am I hydrated for the urine colour. So anything above the red line is fine. If the urine colour is like below the line there, the person needs to drink more water. Okay. So offering the patient a colour chart like that might help them choose the right amount of liquid to use. And so we come back to the top. So overactive bladder management has got so many things we can do. They're all affecting the nerves to the detrusor or the nerves to the bladder or their pathway anywhere up to the brain. So it's complex, isn't it? And you think, well, she came in with a bladder problem, but I'm doing so much else. So, yeah. All of those strategies take time. There is no magic pill, and that's hard for the patient. I want to get better right away. This is really horrible. They have to change their behaviours. If you're changing any neurological things, you need to change your habits. It has to be constantly reinforced day and night. I tell patients it's like training a new puppy. If you let the puppy get away with something one time, that's it. It's so much harder to retrain. Or like a child, retraining them to do something. So the patient has to be on board. The patient has to be motivated. So I always suggest you start with some easy wins. Change the day problems before the night. Leave the waking at night till later in the program. Start with some easy things that the patient can do. Make sure you see the patient regularly, that they do come back to see you. Don't overload them in one education session, not like I've done to you today. I have given you so much information. You'll go home overloaded. It'll be very interesting for you to think back and think, well, what will I remember from that day? There was just so much. So you'll need ongoing support if you're going to change the way you're a physiotherapist. Your patient is going to need ongoing support. That will be you. That will be her doctor. That will be her family. So set up a collaborative plan. Don't say, I'm the physio, you're the patient, you do what I say. Let's work it out together. We're two women together. What's going to work for you? How are you going to keep this going for 3 months? And don't forget medications. There are some good medications out there that calm the bladder. They're called anticholinergic medications, and they are ones that reach the acetylcholine, the neurotransmitter at the motor unit junctions. So there are some anticholinergic medications that mean that there's not so much acetylcholine produced, and so the messages to the bladder are dampened down. So, we're coming to the end. What will you take away from this last presentation? Because this is the one that has really been the true physio management, encapsulated in an hour and 20 minutes or whatever it is. I hope you're motivated. I hope you feel like if I had a patient come to me, I could actually do something. I might be able to start them off and then work with a women's health physio to increase our collaboration. I want you to understand that physios have so much to offer patients that have bladder dysfunction. The Kylies of this world need us as physios. But we need a partnership with our medical colleagues. We cannot do this alone, so don't think that you can or you should. So that's the end of I've got one more bit on here. Your actions. Go away from here to make sure you learn more about the bladder and pelvic dysfunctions. Get to know your local gynecologists or urogynecologists or GPs and talk to them about the skills that you have started to learn. When you get a patient from a medical colleague, make sure if you can't deal with it, you refer back. So you're back and forth, and that gets a good communication going. And visit some pelvic floor physios. There are plenty in Thailand. So if you're just getting into this field, go and visit an expert. Go and visit someone you know who's doing this work and learn from each other. So that in Thailand, the women of Thailand have a really good system that they can get conservative therapy from physios everywhere. Not just Bangkok, but everywhere in Thailand, thanks to everybody online. And that's the last part of my talk, a bit of a motivation talk for you. So I'm going to, before I let you go back to Kylie. Let's find Kylie again and see if you could you explain to Kylie the likely reasons for her leakage and the role of pelvic floor muscle training in its management? Do you think you have enough information now to do that from today? You've now got 2 minutes to talk to people around you, or if you're on your own, to sit and think. What are you going to say to Kylie? Talk now. Okay, so we have 2 things that I want you to come up with. The likely reason for Kylie's leakage, and secondly, how pelvic floor muscle training will work. Would anybody like to offer, the microphone will come around the room, offer some reasons for her leakage? Call out then. I'm listening. It might be the polite Asians, not Australians. Australians would be, all right then. Okay, let me tell you some likely reasons. I haven't taken a full history of Kylie, but I think that her third birth, large baby and a fast labour, could have done some damage to the ligaments that support the bladder in her pelvis. Secondly, I think that with that damage, and she's now started to go to the gym twice a week, working full-time in her shop, she runs it, she's got to lift, carry, pull, push, all that, and she's got 3 little children at home and say, mummy, lift me up, cuddle, and she's lifting and carrying at home. Her body never gets a rest. She needs to reduce lifting, the frequency and the weights that she's lifting, so that she's got some time for her body to rest. They're the 2 big things that you should take away from Kylie's story. Birth damage and lifestyle on top of it. Now, we haven't made any decisions about her pelvic floor muscles and the role of pelvic floor training in her program, her management. So I'm going to now give you a new slide. I forgot to put that on the screen. So we'll go through this. We've done all that. Okay, here we go. So I've now done a physical assessment. The first dot point I'm going to offer you is, what if you found her pelvic floor muscles were actually really strong? They were responsive, they had good occlusion around my finger. She could hold for 30 seconds. She relaxed fully. Even when she coughed, she had a reflex action of her pelvic floor. She doesn't need pelvic floor training at all. What are you going to do? All of a sudden, your world has fallen apart because you were going to give her pelvic floor exercises and now you can't. You've got to look at her lifestyle. So her lifting, her carrying become the prime reason. It was a likely cause that she might be leaking before you found out about the muscles. Now you know it's not the muscles. It must have been the birth damage, that maybe some stretched or torn ligaments, and then adding all this intra-abdominal pressure every time she lifts, every day, and she does more at the gym. So your advice is going to be not what she wants to hear. It's going to be reduce your weights, give your body a rest, maybe do some lighter work, maybe some yoga, maybe some Tai Chi or something like that, that's going to still work her body but in a totally different way. Okay, second dot point. I do a vaginal examination. I find her muscles are weak. She can hardly close around my finger. Sometimes she gets the motor pattern right, other times she doesn't. It's incoordinate. She can only hold for 4 seconds maximum, and when I ask her to cough, the whole pelvic floor just drops down. What would you do for Kylie then? This one's easy, not a trick question. Pelvic floor muscle training, exactly. She needs a decent exercise program. Don't worry about her lifestyle. Well, you'll ask her to reduce her weights temporarily, just while she's increasing the strength of her pelvic floor. So you'd say, look, for the next 3 weeks, I don't want you to do any lifting. Go to the gym and do a totally different program. It's not forever. It's until your pelvic floor muscles get enough strength so that you can manage a gym program. And then we'll gradually increase the weights that you lift until you can do the heavier weights with no leakage. Okay? So you can see why a vaginal examination and a good assessment of the muscles themselves is so important, because it changes the treatment completely. You would do a totally different program depending on what Kylie comes up with in her physical assessment. All right, so that's Kylie. So you've come to the end of the day. We have a question at the back. Microphone.
If Kylie don't have problem with the pelvic floor muscle, and if she would like to have lifestyle, the same lifestyle, did you prefer to increase strengthening of the back muscle and abdominal muscle? Is this help? I mean, because even though the pelvic floor muscle is still strong, if we increase layer power or strength of both core muscle, is this help for her to perform the same lifestyle?
It might. It would be worth trying. If she refuses to not lower her weights, then you've got to think of other things. And one of the things that you could do is to look at her form, the way she does her exercises. Is she doing them in a way that she's not using the muscles of the capsule, the diaphragm, the back and the tummy? And then you're right, giving her some postural exercises, not just standing posture and sitting posture, but dynamic posture. What posture to hold when she's lifting weights, what posture to hold when she's doing high steps. So you may be functionally strengthening the abdominals and the back muscles. You might do a test. Now, has she got weak abdominal muscles? That would be a very good thing to do, or weak back muscles. Yes, I agree. Thank you for bringing it up. I had left that out. So everybody take note that she may need strengthening of her abdominal muscles and her back muscles so that the whole capsule, the whole core is strengthened, and that could be isolated or it could be functional in the gym work that she's doing. Thank you. Are there any questions from online? Just before we go to any online questions, with Kylie and with every patient, I'm sure you do this anyway, this is basic physio. Remember, the patient needs to have her problem explained to her. Possible causes, just like we've been talking about. What treatment options she has. She might not like your physio possibility, so you could offer her something outside of physio. I don't know what. I think we're the best. And her expectations. How much does physiotherapy cost a patient here in Thailand? Is it expensive? Now, does she need to know how many treatments she'll need for budgeting her money, the time frame? You need to give her some take-home information, so you'll need to have some information sheets. She needs to know your expectations. I'm here to help you along. I need you to do your part, I'll do my part. And if something doesn't work out, what are options? You don't need to bring this up at the beginning, but she might need to know if there's any other options if her initial treatment is not successful. But I think with Kylie, you would have enormous success. She is a physio dream to have, the sort of patient that you can do a lot with. Okay, any questions online now? The first one, is there a test that can differentiate between tight and weak pelvic floor muscles? The best is the vaginal examination, because by inserting a finger and being able to feel the pelvic floor muscles, you can assess what the resting tone is. And you can assess the resting tone and the active tone. So you'll know whether the muscles are tight. And then when you ask the patient to squeeze or lift and they can't do it, then you'll know on top of the tightness, you actually have weakness as well. And it's actually really common in patients who have chronic pelvic pain, that they're holding their muscle tight all the time, like semi-tight, and they don't know how to let go. And their muscle is too weak then to tighten when they need to, like with a cough or a jump or something like that. So the best test is palpation, vaginal palpation, to be able to do both of those. Can you see it on ultrasound? You can't see the tightness, you can't see the resting tone of the muscle. You can, though, see whether the patient can lift and relax the pelvic floor. But that's just the movement available, not the tightness or the weakness. So palpation is the answer to your question. Second part is, if we found tightness, should we add the strength to the pelvic floor muscles? A complex question. Should we add strength to muscles that are already tight? If they are weak, the answer is more easy to answer, and it's yes. So if they're tight and weak, add some strengthening. But, there's a big but, if you strengthen too much, you might make the muscles tighter, and that could be a problem. So it's a real balance. Your question is complex, and it might depend on the patient. It might be that you get better results by doing the relaxation training, the down training, the letting go training, and let the patient understand, really perceive in their brain what it feels like to let the muscle go without feeling like the bladder's going to leak, or I'll get more pain, or something terrible will happen. It's get them to let go first. Then once they've got that, you might then add some tightening in. Now, one of the best ways to get an understanding of letting go the muscle is what you would do in any neuro patient. Do a differentiation between a state of contraction and a state of relaxation. So you might get your patient to tighten the muscle, feel that, understand that. Now, let it go. Feel that, understand that. Now do it again. Tighten, understand it, feel it. Now let it go and feel that, understand that. So your voice, your slowness, all that helps. When they've got that, stage 3 is now let's tighten the muscle so that you're getting some strength to this. Let's tighten. 1, 2, 3. Now let go and relax back. If they lose the relaxation by adding the strength, it's too early. They need more practice at just the contraction and let go. So it might be a slow process, person who asked this question. It's a really complex one and an excellent question, I might say. I hope that helps if you have patients like that. Thank you. More questions? Do Kegel exercise help the pelvic floor strength? I've gone the whole day and I have not used the word Kegel. It's not an official word in the professional world. On TV, influencers, on TikTok, on everything else, people go Kegel, Kegel, Kegel. Does anybody online or in this room know what or who Kegel was? Kegel is the surname, the family name of the first doctor who devised pelvic floor exercises for bladder dysfunction. So you are really just saying this is an exercise devised by a particular doctor. If I had an ego the size of the world, I would say you should be doing Sherburn exercises. It's like that. It sounds ridiculous. It sounds silly. So can I please ask you, in your professional life, to never use the word Kegels. Use pelvic floor muscle training. It's a lot more syllables, a lot more to say, but it's correct. And Kegels are only in the social media sphere now. Nobody in the medical field really uses Kegels anymore. And if they do, they shouldn't. That was a bit strong, wasn't it? I landed on you on that one. Sorry. Okay, next question. How soon do mothers in Australia visit the pelvic floor physio after delivery? In the case of Kylie, I wonder if she has been to her pelvic physio after the birth of all 3. Excellent question, thank you. So, mothers in Australia visit a pelvic floor physio at around 6 weeks postnatally in a normal delivery. Not everybody comes, of course, because many women feel totally fine after 6 weeks. The ones who do come are usually the ones who've got a problem. And for some of them, they then come earlier. They might come at 2 weeks or 3 weeks after birth because they have got pain. They want someone to check their stitches. They want, is there still bruising there? I'm having trouble weeing. There's all sorts of reasons they might come sooner, but on average, 6 weeks. Why 6 weeks? Because they have seen their doctor about 6 weeks, and we know from our understanding of contraindications or precautions for doing a digital examination, a vaginal examination, that you shouldn't do one before 6 weeks. So they can come at 6 weeks and safely have a full pelvic floor assessment with a vaginal examination. The second part of this question was, in the case of Kylie, I wonder if she's been to the pelvic physio. I wonder that too. She should have come, definitely. I suspect she did because she said that she had been doing the exercises, but we don't know. Did she do the exercises because someone in the hospital handed her a leaflet and said, do these exercises? Or did she go to a pelvic physio? I didn't put that in the case study, and because it's not a real patient, I have no idea. She's made up. She's not real. So it's a good question to ask, though. Here we have another one. Are there any differences in protocol or where to focus at in 20 plus, I presume you mean age, in young postpartum women and 40 plus women when all have leakage at the same level? I presume 40 plus single women means that they haven't had any children. Not in general. You take a history and you do a pelvic floor program that is suitable for each one. So in the young postpartum woman, you're going to take into account all the trauma her pelvic tissues might have gone through. But when she's only in her 20s, everything springs back to place beautifully. Do you know that the best age in this 21st century, best age to have your first baby is age 24? Now, I was telling my university students this in a lecture one day, and most of them are around 22, 23. None of them had boyfriends at that stage, or some had boyfriends. They weren't thinking about getting married or having a baby at 24. But in terms of healing and getting back to normal lifestyle, having your babies young does work. So to answer this person's question, where to focus your protocols for the young postpartum woman, yes, she still needs pelvic floor exercises, and if it's not immediate, it's for the next baby and the next. It's getting good habits. For the 40 plus woman who's not had children, then the exercises are still the same, and you do your dosage according to what you find in your assessment. There's no blanket rule. It's what you find on your assessment for that patient. The exercises are still the same. It is still a pelvic floor exercise. Note, not a Kegel. Okay, are there any patient-reported outcome questionnaires that you suggest for the clinical setting? There are heaps. And because today was a one-day seminar with no practical sessions, I decided to not bring in any outcome measures into the program. But if you started to do this work, yes, there are lots of PROMS, patient-reported outcome measures, PROMs, that you could use. The ones that I suggest, because there's such a good suite of them, are the ICS ones, or the ICI. Remember me mentioning this acronym? ICI, International Consultation on Incontinence. They have very simple 3-question outcome measures for urgency, for stress incontinence, for prolapse, for bowel, and many of them are translated into many languages, and I'm sure many of them are translated into Thai as well. Just while I'm on languages, in Australia, you might like to write this down, we have an association called the Continence Foundation of Australia. Look on their website and look under the tab that has patient handouts, and there's about 27 different languages that all the pamphlets are translated into. Now, I did forget to look to see if Thai was one of those languages, but you could do that investigation yourself and see if there are Thai handouts. But the ICI questionnaires are excellent. They've got really good reliability, reproducibility. They've been used in thousands of research projects. So I would start there, and you might get all you need from that.
Hello, Kap. Do you have any question in outside? Okay, no more question.
Okay, everybody. Dinesh and I would like to thank you so much for inviting us here today. It's been a really good experience. You've been a lovely audience. Of course, I haven't been able to see you online, but in this room, we've had some lovely, eager faces, and thank you very much for your questions and for your attention all day. I wish you all well, and I hope that you do go into this field of physio, and if you do, that you have a very wonderful career in the field. You will need a lot more education, but today's been a starter. Hopefully it's excited you to think that you might be able to do this sort of physio work. Thank you so much.
Thank you so much. Thank you so much. Thank you for your presentation. It's a perfect presentation and a nice demonstration. Thank you.
Thank you very much, everyone, and we wish you all the best. And thanks to Praparson, Mr. Chanat for organizing and sharing the same vision to make this effort and introduce the awareness of women's health physiotherapy in Thailand. And I am optimistic a few of you will take this leadership and start getting onto this journey of helping many, many women who may be suffering in silence. Thank you.
Thank you, Dennis. Thank you. Thank you so much together.
It's been a pleasure.
โอเคสำหรับคู่อบรมออนไลน์นะครับแล้วก็ออนไซต์นะครับทางบริษัทประภัสสอนขอขอบคุณมากๆครับยินดีและเป็นเกียรติมากๆครับถ้าผิดพลาดประการใดก็ขอโทษด้วยก็สามารถคอมเมนต์แนะนำทางเราได้นะครับเราจะไปปรับปรุงในครั้งหน้าทางนี้ก็ขอบคุณครับเดินทางโดยสวัสดิภาพนะครับขอบคุณทางฝั่งออนที่เป็นออนไลน์ด้วยเดี๋ยวเราถ่ายรูปร่วมกันสักรูปหนึ่งนะครับตรงฉากด้านหลังนะครับก่อนกลับขอบคุณครับ
Picture time.
Take a photo.
Sure.